do it is to just be involved in the chat while we talk, and I will look to see who's active, and I'll probably call on you a bit more. And then if I see that people, if there's anybody that isn't really active or whatever, or if their mic isn't working, you can also just let me know, like, hey, my mic's not working. All right. So any questions before we get started? No? Okay. So for this case, so for this case, the history is a little different. I added some things to the history last night, and then you guys didn't have a ton of the rest of the history as well. So it'll be a little bit more of you asking what you want to know, and we'll kind of go from there. I'll guide you as we need to. Okay. So we have a 45-year-old female with history of hyperlipidemia who presents with sudden onset abdominal pain for the last 8 hours. She's had intermittent sharp pain over the last week, and she's had pain in the past, and it would usually she's had this pain in the past, but it would usually improve on its own without any intervention. So, Dr. Danielle, what are you thinking of with her history and the description of her pain? Okay, so Dr. Brown, what are you thinking of?
So you see, wait, am I, me, Dr. Brown, or is there another Dr. Brown?
Yeah, you, Dr. Brown.
Okay. So you can see by her case with her hyperlipidemia, I was assuming that could have something to do with the abdominal pain, maybe?
Yeah, so it can. What are some things? So if somebody has high cholesterol, basically that's what hyperlipidemia is.
Mm-hmm.
What types of abdominal pain can that cause, or what are the causes of abdominal pain that can be a part
of? Abdominal pain, maybe something with the liver.
Something with the liver, yeah. So do you know what?
Yeah, I'm not quite sure. Sorry.
It's okay. So when we have elevated cholesterol in the blood, the liver processes the cholesterol. Sometimes what can happen is the cholesterol and the fats in the blood become so high it can cause inflammation to the liver, and it can cause fatty infiltration into the liver. So it changes the way that the liver is, I guess not organized, but it changes the architecture of the liver in a way,
right.
And it can cause some inflammation. Okay. So we can have hepatitis due to
hepatitis. That's what I was thinking of.
Yeah, so it can be hepatitis due to elevated fats. What else can cause abdominal pain related to hyperlipidemia? So Dr. Danielle is saying that maybe extra abdominal causes such as MI. So definitely, and one thing to talk about there is, like Dr. Gutierrez is saying, that if it was like an MI, it's basically because there is narrowing of the vessels because there's too much cholesterol there, and so what can end up happening is you can have a heart attack, or you can also have narrowed vessels in the abdomen as well. And I think Dr. Gutierrez was saying ischemia, and that would be related as well. All right, so Dr. Ochiaga, Dr. Sean, what are you thinking of?
I was maybe perhaps thinking about cholecystitis, maybe.
Cholecystitis?
Yeah.
Yeah. So why are you thinking
that? Maybe due to her diet, like maybe because I was looking also like of the vomiting as well. Like it was like
Yeah.
non-bullet vomit, so maybe there might be like a lack of bile.
Maybe. So non-bilious vomiting. We'll get to that. It means something a little bit more specific, um, but you're right that her diet might be involved, and that's one of the reasons why she would probably have high cholesterol. But the other thing is that your bile, and if we're thinking if it's a gallbladder problem, what we typically think of is gallstones. And so those gallstones are made up of some, well, not all of them, but most of them are made up of cholesterol. So there's cholesterol in them. So if you have high cholesterol, you're going to be a little bit more prone to forming those gallstones. Additionally, why do people with gallstones have pain, Dr. Sean?
Perhaps because because the gallstones could travel down to the lower like abdominal cavity, so that could cause a lot of pain as well.
Yeah, but so it can. But what is typically the cause of pain? Why does a gallstone cause pain? Is it because it's traveling, or is it because it gets stuck?
Perhaps it gets stuck.
Yeah, it's because it gets stuck, right? So it gets stuck in somewhere in that biliary tree. A lot of times it's that opening from the gallbladder into that common bile duct. If it gets stuck there, that gallbladder is no longer able to contract and push out that bile. You start to build up fluid there. It gets inflamed, and it causes cholecystitis. It causes an inflammation of the gallbladder that can lead to an infection. So yes, you're right. It can definitely be the gallbladder. I think there was another. So Dr. Mount is saying obstruction. That can definitely cause upper abdominal pain as well. Like a small bowel obstruction can do that too. Yeah, so good. All right. So that I was talking about hyperlipidemia. What about Dr. Madison? What about the sudden onset abdominal pain for 8 hours? Plus the fact that she's been having similar intermittent sharp pain over the last week. What are you thinking about with that?
Hello, is my mic working?
Yeah.
Hello? Oh, hi.
Yeah.
I would be worried, because it doesn't say, I would be worried what was she doing before all this happened, because something must have triggered this for going on for a very long time, for 8 hours. So I'd ask her what she was doing.
Yeah, exactly. So she was eating breakfast.
Breakfast.
What does that tell you?
I'm not sure.
She was eating eggs and bacon and some hash browns and some sausage there too. So
yes, it's her diet. Yes.
Okay, so what's specific about her diet?
It's filled with high fats and greasy things that could lead to cholesterol or something. That's what I mean. High cholesterol.
So she has a lot of fats in her diet. So she was eating this really fatty breakfast, and why is that going to cause you pain?
Not many reasons, but for this, it could affect her like stomach and her like her veins too. It could clog her veins. Her body can't process all of this like high cholesterol stuff too fast. It's like slowing down, which could lead to other things in her organs to slow down as well.
Close. Yeah. Close.
That's close. Okay.
Yeah, that's close. And that's a good thought. That's actually a really good thought. There's something aside from that. So Dr. Mount, do you want to help out?
Yeah, so bile's function is to emulsify fats. So it basically breaks into smaller pieces for absorption. So maybe if there's a blockage with the gallbladder, that would affect the ability to break down fats.
Yeah. So if so what happens when you eat? Why is that going to be the cause of pain?
Well, I think it's like, I'm not too sure, but the liver is producing the bile. I mean, and then the gallbladder is like storing it and then secreting it while you're eating, specifically.
Exactly. Exactly. So as you eat, and specifically as you eat fatty foods, your gallbladder is going to clamp down to push all of that out. So if there's a blockage at some point of the gallbladder, you're now unable to push that out. You're starting to strain the gallbladder against a fixed blockage. You're going to cause inflammation. You're going to cause swelling in that area, that causing you to have cholecystitis or inflammation of the gallbladder. So yes, definitely after you eat. Is there anything else that would cause pain after you eat, Dr. Mount?
I'm not so sure.
Okay. Anybody else know? You can just
Oh,
talk.
maybe.
Uh-huh.
Is it like acid reflux?
Maybe, yeah. So acid reflux you're gonna have pain after you eat. Similar. Well, let's go with like the stomach area. What else can cause pain after you eat or as you eat?
Someone said ulcer.
Okay, good. How does an ulcer cause you pain?
Yeah, I'm not too sure about like what that is doing.
That's okay. Dr. Miller, can you explain why an ulcer is going to cause pain?
An ulcer would cause pain because isn't that when a sore develops in the lining of usually the esophagus or stomach? And then if food were to come in, then you're gonna also have stomach acids irritating it more so.
Yeah, so as you eat, your stomach is going to produce more acid. And so if you have an ulcer there, it's going to cause more, if you put more acid on it, the way that I think of it, you put more acid on it, it's going to cause more pain. Your area is going to be more acidic because you need to break down that food. What if I told you that it got better as she ate? What are you thinking of in that similar thought, Dr. Miller?
I'm not exactly sure.
It's okay. Dr. Neri, do you know?
Could it be yeah, I don't know either. Could it be something with her bowel?
Yeah, so her small bowel. So if we had, so you can have an ulcer in the stomach. You can also have it in the small bowel. You can have it in the duodenum, right? So if we eat, why is it going to get better if you have an ulcer in the duodenum? Why is it going to get better as you eat?
Because when you eat, it makes that acid, like it neutralizes the acid, right?
Yeah, what does that?
The food.
Not the food. There's a specific organ, and there's a reason why I called on you.
Oh,
right?
the pancreas.
Yeah, the pancreas. Yeah, good job. So you said the answer without saying it. So the pancreas is gonna push out these buffers to reduce the acid in the duodenum, because your duodenum's not made to see the acid of the stomach, right? It's gonna see it because that the food contents are going to get dumped into the duodenum, but your pancreas is going to be there to help buffer that out, so you're not damaging the duodenum. So as you eat, your pancreas is going to want to push some of that out, and that if your pain got better with food, that will tell you that maybe there's an ulcer in the duodenum. So good. All right, and you're saying the pancreas is not sending out buffers. So other than, we talked about the gallbladder, we talked about the stomach, what else can cause pain?
Oh, me?
Yeah, you.
Pancreatitis, right?
Yeah, pancreatitis, right? So why is that going to cause pain? And why is it going to cause pain after she eats?
Because when she eats, the pancreas isn't sending enzymes, and the enzymes are getting trapped and stuck in the pancreas, causing the digestion of the pancreas.
Yeah, so typically with that, what are you going to have within the pancreas? Like what's gonna be a cause of that autodigestion and that inability to secrete things?
The lipase?
No.
Oh, a blockage.
Yeah, blockage. It's a lot of telling me what I'm thinking. So you have to have some type of blockage there. So a stone, pancreatic cancer can cause that as well. So yeah, so if you have you're going to have pain after you eat, because as you eat, your pancreas is going to want to push out these enzymes and push out the buffers and all that. And so if you a lot of times with pancreatitis, patients won't be able to eat because, one, they'll probably vomit like right after, and two, it can worsen their pain. And so so pancreas can be another cause of that upper abdominal pain. Dr. Luis, anything else in that area that can cause upper abdominal pain?
Well, I was thinking her upper GI tract.
Okay. Like what?
If she's not processing her food correctly, if she's not digesting it correctly after the fact.
Okay. Okay. What else is in the upper abdomen that can cause her pain? So we talked about the stomach. We talked about like the duodenum and all that. What else can cause the pain?
Well, we already mentioned. Did we end up mentioning liver? We did, right? We said it was in the liver.
Yeah.
I guess it's just the spleen there.
The spleen. The spleen is another one. There was one other thing that I was going to tell you guys, but I forgot it.
Could she be confusing these?
So, I'm sorry?
Could she have been confusing it, like her upper abdomen with like her lower chest, or is that not the case here?
Yeah, no, for sure. Yeah, exactly. So what are you thinking about there?
Well, I was thinking if it's her lower chest, maybe it's the heart instead, and she's just mispositioning where her pain is.
Yeah, she can be having a heart attack, right?
Yeah, I was originally thinking she has like plaque in her arteries too, would cause like enlargement of the vessel, and a high cholesterol diet once she eats it would just kind of like push it.
Yeah, so like something like angina. Dr. Neri is saying maybe a pneumonia, so that is also a possibility. What if I told you that she started that her and her family went out to eat about a few days ago, and they started to have like yesterday they started to have a bit of a fever, they started vomiting, and now they're starting to have diarrhea? What would you be thinking of?
I totally think she has food poisoning of some sort, or she ate something that just didn't sit well.
Yeah, exactly. Some type of food poisoning, gastroenteritis. Exactly. Perfect. All right. So she's been having pain over the last week. It feels like a sharp, sometimes cramping pain. Usually after she eats, lasted anywhere between 5 and 15 minutes. So we know that she is having some type of pain there. It's pretty consistent with what she's having now. The only difference is that it's lasting longer now. So Dr. Saji, why is that important to know?
Hello?
Hey.
Oh. Can it like distinguish between if it's something that's like acute or like chronic?
Exactly. So if she's had, I think I said in here that she's had similar pain in the past. So this might be something that's a chronic type pain, a chronic type issue, and now it's getting acutely worse. So that would be something like we would call it acute on chronic, versus if this was just, it happened this morning and that was it. It's been going on for 8 hours. It's more of an acute pain. What if I told you, well, for her, it's been this specific pain that she's having has been going on for the last week, and suddenly worse today. So what would you call that?
That it's developing into something that is chronic.
Or not necessarily something chronic. It can still be something acute, but we would call it subacute, right? So it's not exactly chronic. It's not exactly acute because it's been going on for a while, so it's called subacute. So the important thing with all of that is that it's getting better or worse?
Worse.
Yeah, so whatever is going on with her, it's getting worse. And that's going to tell us that we need to intervene probably more rapidly, right?
Mm-hmm.
Okay. All right. So this morning she had 2 episodes of non-bilious, non-bloody vomiting with the onset of the pain. She feels nauseous still, but she has no fever, but she had some chills. So what are you thinking about with that?
Um,
Dr. Luis is saying morning sickness.
could we like check her for a pregnancy test?
Yeah, we definitely can. She's 45, so that's on the upper age. You can still get pregnant at 45. But yes, we can definitely check her for, we can get a urine pregnancy test. So non-bilious, non-bloody, what does that tell us?
That there's no bile when she was like vomiting.
So if there was bile in her vomit, what would we be thinking of? So how does your bile get into your GI tract?
Doesn't it like come from the gallbladder?
Yeah. Well, it comes from the liver, and the gallbladder helps store some of it. But it travels down and it enters your GI tract in what part of the intestine?
The small intestine?
Specifically the duodenum, right? So that first part of the small intestine, as it leaves the stomach, that's where your bile empties out into. So, with that, why would you have bilious vomiting?
Could there be like a low amount?
So how does the which direction does the bile usually flow? Up or down? As it enters the intestine, does it go down towards your colon or up towards the stomach?
Up towards your stomach?
The other way, right?
Oh,
so you
down.
have bile that enters the intestine. It mixes with the contents that your stomach puts out into the small intestine to help break it down. And it travels down and eventually becomes poop, right? So if it typically goes down and you're vomiting, why would that cause? Why would it be going up? What would need to happen for it to go up? And just think of it logically.
Is it a blockage?
Yeah. So there is some type of blockage down below, right? That's not allowing that bile to flow downwards. And so what ends up happening is if it can't flow downwards and your liver and gallbladder are still pumping that bile in, it'll start to build up and you'll start to vomit it up, right? So if there's some type of blockage after where the bile gets emptied into the intestine, you can have bilious vomiting. I know I pushed you a bit on that one. Does that make sense?
Yes.
Okay, good. All right, what about bloody vomit? What can cause bloody vomit?
Could that be from something bleeding out?
Yeah, so like what?
Could it be like the liver or kidney or anything in the upper abdominal area?
What's more likely? Well, if you're vomiting blood, it has to be in the GI tract, right? It has to be within the stomach, the duodenum, somewhere in there. So what mostly the stomach. So what's going to cause you to have bloody vomit? Like, what's one thing that can cause you to have bloody vomit?
Like an illness specifically, or
Yeah.
the ulcer?
Yeah, like an ulcer. An ulcer will definitely cause you to have some blood in your vomit, especially if it ulcerates into a vessel. So good. All right. Dr. Let's see. Dr. Shikar, we say that she doesn't have, she denies a fever, but she has some chills. So what does that make you think of? All right, let's go with Dr. Patloa.
So if she didn't have a fever but still had chills, I kind of took it as it's still similar symptoms to if you have gallstones, you might have a fever and chills. So that's why I kind of still took it as maybe it's another hint towards gallstones.
Yeah. So, but what is it? The gallstones themselves that cause the fever and chills?
The inflammation caused by the backup of the bile.
Yeah, and so eventually, what's going to happen with that backup?
Could it cause it to rupture?
Cause it to rupture is one. What else? What's going to cause a fever usually?
An infection?
An infection, right? So typically with fever, the first thing most people think about is an infection, and that's okay. Other things can cause a fever, but it's a good thing to immediately think infection, because infection generally will kill you before other things will, right? Mm-hmm. So if she has no fever, she says she has no fever, does that automatically rule out an infection?
No.
No. Especially with the chills, right?
Yeah.
Chills are another sign of infection. Mm-hmm. And so if you were thinking maybe infection, what's something that you want to take a look at?
I'd want to get a blood test and check out her white blood cell count.
Good. Before that, what would you want to do?
If she has an infection.
Yeah, part of your physical exam, something we get all the time.
Take her vitals and
take her vitals. Check her temperature.
Yeah.
So yeah, so with that though, what is something that's going to be important to ask her in her history? Like let's say I tell you that her temp was 100. Does that mean that she has no fever? Because technically it's not a fever, right?
So what her normal baseline temperature has been at home?
Let's say it's normal. It's usually normal. What is something you need to ask her to make sure that temperature is correct?
I'm not sure.
Dr. Brown helped you out in the comments.
Oh, what medication she's on?
So what medication specifically is going to cause her temp to go down? We give it all the time for fevers.
Oh, fever reducer? So just like Tylenol?
Yeah. So if you're thinking of infection, you have to always ask you have to think about when the last time they took anything that will reduce the fever. So Tylenol, ibuprofen, all that stuff.
Okay.
Does that make sense?
Yeah.
Okay. All right. So anything in the ROS that you found important. So she denies hematemesis, hematochezia, melena, fevers, weight loss, night sweats, diarrhea, dysuria, chest pain, shortness of breath. Anything in there that's important or anything that you weren't sure about?
Well, since she wasn't vomiting blood or she didn't have blood in her stool, that made me kind of, be able to rule out if there was any like ulcers or bleeding or perforation or any of that.
Good. Okay, good. What else? Anything else in there?
She denies chest pain and shortness of breath. So that made me, I was reading that shortness of breath could also be caused if something was like inflamed and pushing up on like the thoracic cavity, if something was really enlarged. So since she denies that, I think there isn't anything that's being like abnormally swollen or anything.
Good. All right. Good. Okay. Let me see there. And then the rest, honestly, it's not super, super important. Okay. I think I pretty much called on everybody. All right. So since we have a smaller group, anybody can really answer. You guys can just answer it as you'd like. So her past surgical history shows she has a history of C-section ×3. Why is that important?
Doesn't it indicate that she was pregnant 3 times previously?
So she was.
Then.
Oh yeah.
I would ask her if she's felt these symptoms or similarly before in previous pregnancies.
Okay. So, so you think that she might be pregnant now?
Potentially, yeah.
Yeah. So especially if we're thinking like morning sickness, maybe she's pregnant. Maybe she has an ectopic pregnancy. That's also a possibility. So definitely. Dr. Brown, you're saying complications from surgery. What do you mean?
I was just thinking either like previous infections, like she might have a history of like whether it's, I don't know, like some sort of medication given to her during surgery or during those C-sections, or even if she had problems recovering from those surgeries.
Maybe, yeah. But her last surgery was about 10 years ago. So.
Oh, okay.
What happens if somebody has like repeated surgeries in the abdomen? What can happen?
Couldn't that cause maybe like either irritation or some sort of prone to bleeding there?
It can cause irritation, but it's in the form of like
scar tissue.
Scar tissue, adhesions, more likely. Okay. So you irritate the abdominal cavity; those intestines will tend to stick together, and so if they stick together and they're not moving as well, it causes an obstruction because you're not able to move and push that poop out as we normally would. So that can cause a bowel obstruction. Dr. Gutierrez is saying possibly an SBO, and yeah, that can be it. Dr. Danielle is saying possible pelvic organ prolapse or scar tissue connecting these. So pelvic organ prolapse can definitely cause some discomfort, but it wouldn't cause nausea. It wouldn't cause nausea, vomiting. It wouldn't cause this upper abdominal pain. But you are right that you muck around in there, you can weaken the ligaments, cause some prolapse. Good. All right. So Dr. Brown, we'll stay with you. Vitals. So her blood pressure is 135/84. Heart rate is 92, respiratory rate is 18, temp is 100.1, and O2 sat is 99. Anything there stick out to you?
Not necessarily. I mean, maybe her blood pressure is a tiny bit high, but also I'm not sure if that's like something to really look at. Her O2 is fine. Maybe her heart rate's a tiny bit up, but like, if it's bound by 100, then it's not too high. But we also don't know the medication she's on, so that temperature of 100 could be a sign of a fever if she's already taken a fever reducer.
Yeah, exactly. So the only thing that really stuck out to me is the temp being 100.1. Even though it's considered normal, in my head I always worry about an infection. So yeah. We're gonna want to know what she took in the past. And I think she actually had taken Tylenol for her pain. So that could be artificially low. The blood pressure is a little elevated. A lot of times when you have pain, and if it's significant pain, your BP is going to be elevated. Same with your heart rate. So, good. All right, Dr. Gutierrez, what physical exam do you want to do first? Or anybody?
Sorry,
What-
my mic, I couldn't get it on.
It's okay.
Maybe like the abdominal region
Yeah.
to check if it's distended or something.
Good. So no distension, but there is tenderness of palpation in the right upper quadrant and epigastric region. So what are you thinking about more likely with that?
In the right upper, maybe the liver, the gallbladder.
Mm-hmm. Yeah, liver, gallbladder. Anything else?
Part of the colon, potentially.
Part of the colon, potentially, yes. What about the stomach? Is that going to cause pain in that area?
Oh yes, the epigastric region.
Yeah. What else in that area?
Pancreas.
Good. Okay. So what exam maneuver do you want to do next? Actually, sorry. Before we get there, the patient also has involuntary guarding and rebound in the right upper quadrant. What does that tell you?
I'm not sure. Sorry.
It's okay. Does anybody want to explain what rebound tenderness is telling us? Okay.
Do you mean rebound tenderness like she goes to like kind of swat your hand away if you try to touch it, or rebound as in like when you press down on it and it comes up, that's when it hurts?
Yeah, you push on it, you let go, and as you let go, that's when it causes pain. So why does that happen?
Okay. Inflammation?
Yeah. So there's some type of inflammatory process in the area. And so rebound again is when you push down and you let go, and that letting go causes more pain than pushing down. And so that tells us that you have pain that's not necessarily specific to that area, because as you let go, there's a wave of movement that causes whatever's inflamed in the belly to get more irritated and cause pain. And so rebound tenderness typically tells us that there is some type of inflammation outside of an organ itself, usually because either something is infected, something has been perforated, or something's bleeding. And yeah, someone on YouTube is saying peritonitis. So that peritoneum is that what is surrounding all the organs in the belly. And so if you have inflammation of that, you're gonna have rebound tenderness. What about guarding? Do you know, Dr. Brown?
Sorry, can you repeat the question?
Do you know what guarding is? Or
is
like
guarding the one where like if you go to touch it, then she like kind of blocks you from touching it?
Yeah, so she's like tensing up, her abdomen feels really tense and firm. So do you know the difference between voluntary and involuntary guarding is?
I'm not sure, but if I could take a guess, one would be like she sees you're going to like touch that area and she like immediately moves, whereas like if you ask her to hold still and then you go to touch it and then she like has a reflex against you touching that area, maybe? I'm not sure.
Yeah, close. It's not necessarily a reflex. It's her abdominal muscles themselves. So as you start to try to push down on the area,
okay.
If she's guarding against you pushing down because she thinks it's going to hurt, she's going to contract her muscles so that you're not really able to push as far down as you would typically. And so voluntary guarding is usually because there's some type of pain in whatever area you're trying to push in, and she's really afraid. She's contracting down. Involuntary guarding is like, even if you tell her to relax and you're pushing down, you still feel it's firm and rigid. And that's a lot of times because there's underlying inflammation in the area. And so involuntary guarding plus rebound tells us that there might be there is some type of peritoneal inflammation, and we probably want to get surgery involved to take a look to see what's going on. Does that make sense?
Yeah, it does actually. Thanks.
Okay, good. Does anybody know the exam maneuver that we're going to want to do next in the abdomen?
Would an ultrasound be one, or is that too like far, too close? I don't know.
We want to get an ultrasound, but what are you thinking of? Why do you want to get an ultrasound?
Maybe you could like look at like the renal tract, or looking at like any abnormalities in like the organs.
What organ specifically are you thinking of?
Specifically, like her liver, pancreas, stomach, like in the areas causing her pain.
Yeah. So we're saying that she has that tenderness in the right upper quadrant. She has rebound and guarding in that area as well. So what organ are we typically thinking of in that area?
The liver.
Liver or
pancreas, or no, sorry, stomach.
Pancreas, maybe.
Gallbladder.
Gallbladder, yeah. Yeah, gallbladder. So, do you know what Murphy's sign is?
No.
Does anybody know what Murphy's sign is? Okay, good. So that means I get to teach it. So, Murphy's sign. Yeah. So, Dr. Neary, do you want to tell us what it is? I think you got it.
So, like, is it like you put your hand under the ribs, and I think you ask them to breathe and see if there's pain?
Mm-hmm. Exactly. So, so these are my ribs right here. I'm going to put my hand right underneath the ribs and tell them to breathe in. As I breathe in, I'm going to start advancing my hand in more in the ribs and keep doing that. And so as they breathe in, you're advancing more. They breathe out. You keep your hand there. You don't let it go. They breathe in again. You push up. And so what that does is you're letting your hand get closer to their gallbladder. And so what will happen is as they breathe in, they'll abruptly stop. So they'll go and just stop like that because it hurts so bad because that gallbladder is really inflamed. And so that's the Murphy sign. And so if they have a positive Murphy sign, we're thinking that there might be something in that right upper quadrant, usually their gallbladder that is inflamed and is the cause of their pain. And so this patient had, I put that the patient abruptly stopped breathing with deep palpation in the right upper quadrant. And so she has a positive Murphy sign. She had no pain on palpation of the right lower quadrant or the periumbilical region. So, Dr. Mount, what does that tell us?
Sorry, could you repeat that? I couldn't hear.
Yeah, so she has no pain to palpation in the right lower or periumbilical region. So what does that tell us? Like what typically causes pain there?
We could rule out anything like in the urinary tract and also the bowels, like maybe the intestines.
Maybe. There's something specific to the right lower quadrant.
Oh, the appendix?
Yeah, the appendix. So the appendix usually will cause pain in around the belly button first, and then it usually will migrate to the right lower quadrant. So typically patients will say, oh, my belly button hurt for like a day or two, and then now my right lower quadrant hurts. So less likely the belly button. The appendix. Okay, good. Any other labs that you guys want to check? Any other exams that you guys want to check?
Could we do a CT?
We can do a CT, but we would probably do that later. And CT probably in this case wouldn't be the best modality. Just saying. We can get an EKG for this patient. It was normal. Dr. Sean, what labs do you want to get?
I'm not too sure. I was also thinking of an EKG as well, but you said that it should be okay. So
Yeah, so the EKG was normal. What about blood tests? What blood tests do you want to get?
probably white blood count, possibly.
Yeah, good. So white blood cell count was 12.5 thousand. So, and we can do the rest of the CBC also. So the hemoglobin was 12 and the platelets were 190. So the white blood cell count, what does that tell you?
I think, is it not normal?
12.5 is a little elevated.
A little elevated? Okay.
Yeah, it's a little elevated. So an elevated white blood cell count, what does that mean?
I guess maybe some kind of like liver damage, maybe.
Not liver damage. So it tells us that there's some type of inflammation, right? So there's some type of inflammation or infection in the area. And it's not specific to one specific organ. It just means that there's something there, right? If you want to take a look at the liver, you would order like a liver function test where for her AST and her ALT, the liver enzymes were normal, and her bilirubin was normal as well. It was 0.8. So what does that tell us if all of her liver function tests were normal?
Then there's probably less likely to be like some kind of like liver condition.
Yeah, so whatever is going on in this patient, it's not causing inflammation of the liver, right? And so the other thing that's important with that is the bilirubin. The bilirubin being 0.8, which is normal, tells us that, if there's an obstruction in the area for the gallbladder, it's not affecting the flow of bile from the liver to the intestine, because what happens sometimes is if we have a gallstone that gets stuck in the common bile ducts, the duct that connects the gallbladder to the liver and then down to the intestine, if there's a blockage further down, everything starts to build up, and so the bilirubin that your liver typically will excrete starts to build up in the blood, and so you'll see it elevated. So that tells us that most likely there's not an obstruction in that area. Does that make sense?
Yeah.
Okay. All right. So, Dr. Shikar, any other labs you want to get? Okay. So we're saying that it might be, so Dr. Neri's saying a BMP. Her BMP was normal. We typically want to see the kidney function, so the BUN and the creatinine. So the BUN is 10, creatinine is 0.8. So those are normal. Dr. Neri, let's say her creatinine was 1.8 and her baseline is 0.7. What does that tell us?
There could be something wrong possibly with her kidney, that like something with her drainage, or probably, or something.
Yeah, maybe. So there's going to be some type of kidney injury either before the kidney, in the kidney itself, or after. So pre-renal, post-renal, or intrinsic renal, right? But so what in her presentation, so let's say she did have a creatinine of 1.8, what in her presentation would be a reason why her kidney function would be bad?
Like presentation, like pain,
or like how she came in. So she came in with abdominal pain, but what else did she come in with?
would it be like she would have like back pain, right?
Maybe. So if there's inflammation in the kidney, you can. But like how this patient specifically came in, so she came in with abdominal pain, but she came in with something else.
Oh, hyperlipidemia.
Not the history.
The
So she felt
C-section?
no, she felt nauseous, and what else?
Oh, she had fever at home and some chills.
So she had some chills, but so she had been vomiting, right?
Yeah.
So when you vomit, you're losing a lot of fluid. So if she was vomiting a lot and she became dehydrated, that can affect your kidneys. And so looking at the kidney function in patients that are vomiting is important to know, how bad is their vomiting, one, and then two, to see if you need to give fluids. Does that make sense?
Yeah.
Okay, good. All right. Dr. Gutierrez. So we're saying that this might have been the gallbladder, and we got some labs for that. It looks like there might be some type of infection or inflammation. What other lab do you want to get?
Maybe look at her lipase for the pancreas.
Good. Exactly. So if we're thinking that she had a gallstone stuck at where causing stuck at the junction between the common bile duct and the duodenum, so right when that bile duct ends, what would you expect that lipase to be?
Pretty high.
It would be pretty high because it's going to cause some pancreatitis, right?
Mm-hmm.
So hers is normal. So what does that tell us?
That it's there's not a blockage there.
There's not a blockage there. So there's not it's not affecting the pancreas. Whatever's going on with her is not affecting the pancreas. So what do you think it is, Dr. Gutierrez?
The gallbladder.
The gallbladder. Okay, so tell me why you think it's the gallbladder.
I mean, it's within the region that she talked about, and we ruled out the liver and the pancreas and the stomachs and the kidneys.
Okay. So what about? So let's go step by step. So what in her history tells you that it's likely the gallbladder?
The nausea and non-bloody and non-bilious vomiting.
Yeah, so she came in with acute abdominal pain, with non-bilious, non-bloody vomiting, and she's been having this pain in the past as she was eating. So whenever that gallbladder was supposed to be contracting, she was having pain, right?
Yes.
So all of that is consistent with cholecystitis, with an inflamed gallbladder. What about in the physical exam? What told us that this is likely the gallbladder?
Murphy sign was positive.
The Murphy sign was positive. She had right upper quadrant abdominal pain. Murphy's positive with some rebound and guarding.
Yes.
So, okay, and then what about the labs?
For the labs, I guess some of the tests, like for the liver, the BMP, all those came out pretty normal.
Exactly. Good. So all of the other labs came back normal. So what I wanted you to do there, and what you did really well, so good job, is to kind of summarize the case, right? So we have a 45-year-old female who's coming in with upper abdominal pain, nausea, and vomiting, with intermittent pain over the last week as she ate. She was found to have normal, slightly elevated temperature, but otherwise normal vitals, with the physical exam showing right upper quadrant tenderness with rebound and guarding and positive Murphy sign. White blood cell count was elevated, but the LFTs and the lipase were normal. So this patient most likely has and you would say cholecystitis, and you would want to less likely pancreatitis, less likely hepatitis, less likely whatever, right? So that's giving your diagnosis plus your differentials, and then from there you would say what you want to do next. So does that make sense? Like how to summarize the case?
Yes, it does. Thank you.
Yeah, good. And you did a really good job. And so for everybody else, I want you guys to start practicing that too, because that is a skill that you're going to have your entire career, and it's going to show you. It's going to show that you really know your medicine if you're able to summarize the case in a very concise way. It'll make you look good when you're a med student as well. So good. All right. So what do you guys want to do for this patient? What imaging do you want to get? Somebody said a CT scan. Any other imaging you want to get? An MRI won't necessarily help you as much unless you're doing something like an ERCP or an MRCP. But those aren't really indicated in this case. Both of those are going to tell us if there is dilation of the bile duct and to see if there's a stone in that actual bile duct itself. So MRCP actually is the MRI version of it. It's probably not indicated. HIDA scan is also probably not indicated because you have to do something first before you do the HIDA. And Dr. Luis, what do you want to do?
I want to do the ultrasound because it's less invasive and it's less radiation to the patient. So
yeah,
there's actually no radiation to the patient. Sorry.
Yeah. So ultrasound has no radiation. So the CT scan will have radiation. So yeah, it is less radiation. So you would want to get a CT scan first because it's fast, it's cheap, and there is no radiation involved, and you can get a good image of the abdomen. And you can also see like the pancreas and the other organs in the area. So her ultrasound showed pericholecystic fluid with a positive sonographic Murphy sign. They weren't able to visualize a stone. So the pericholecystic fluid basically just means that there's fluid around the gallbladder and it looks inflamed. A lot of times you'll have thickening of the gallbladder wall, which I think hers was also pretty thickened as well. And that tells us that there is some inflammation of the wall itself as well. The sonographic Murphy sign is basically they get the ultrasound probe and they do the Murphy sign with the probe. And a lot of times that will be positive if they have a gallbladder issue. The no visualized stone, sometimes we get when they pass the stone, but they still have this ongoing inflammation and all that. So it doesn't really tell us anything. So Dr. Brown, with the HIDA scan, we can do the HIDA scan at this point if we weren't thinking that this patient would, or actually Dr. Brown, what do you want to do next for this patient? And we'll talk about the HIDA scan after that.
You said after the ultrasound?
After the ultrasound, what do you want to do?
Look at the results of the ultrasound and then determine if you need other tests.
Yeah.
Or other imaging scans.
So does this imaging confirm that we have cholecystitis?
Wait, is the imaging included in the history sheet? Sorry, I didn't see it.
Oh, it's not. So basically the imaging shows the pericholecystic fluid, so fluid around the gallbladder. They had a thickened gallbladder wall, so that tells us there's also
so
inflammation.
I would say that there was inflammation if it was thickened. Yeah.
Yeah. So this ultrasound with the patient's history basically tells us that this is probably cholecystitis. So
then we probably wouldn't need any other imaging, right?
Yeah. So what would you want to do?
Could we go ahead with treatment, or is that too much of a jump?
Yeah.
Okay.
Yeah. So what do you want to treat it with?
That's a good question. Is there medication specifically that are used to treat cholecystitis?
Yeah, we can give antibiotics, but do you want to give antibiotics for this patient? We do. We do want to give antibiotics. But is that all we want to do for this patient?
No, I mean if I'm not sure if there's a surgical procedure that needs to be done, but I also, yeah? Okay.
Yeah.
Someone's got to
surgery.
remove it.
Yeah, we would just remove it because
Okay.
what ends up happening is that if you treat it with antibiotics and it gets better, that patient's going to be prone to have that inflammation and infection again.
Oh,
and
okay.
so it's like, do you really want to leave that in? Because what if next time if the gallbladder perforates and now you have just a bunch of bacteria and bile all over the abdomen, and you have to open up the patient to clean it out. So,
but the only thing I'm worried about though is that without her gallbladder, then wouldn't she have some of the same symptoms that she was like kind of coming in with? So like she'd have no way to secrete like bile, or that?
No,
like,
so
to store. Sorry, not to secrete, but store.
Yeah, so it's a storing mechanism. So the gallbladder is going to store the bile. What will happen without the gallbladder is that you'll just have a constant flow of bile down into the small intestine, and so your liver will just basically keep making bile, and you'll keep pumping it into the intestine.
No follow up. Would that cause acid reflux?
Not necessarily, because remember the bile is going to enter the GI tract after the pylorus, after the stomach, and so it wouldn't necessarily cause reflux.
Okay, yeah, but she'd have to change her diet, like I think Dr. Shikar said.
yeah. So she would definitely need to change her diet. You can still get gallstones without a gallbladder, which sounds counterintuitive. It's not very common, but I've seen it before. But yeah, you would want to change your diet if you can. Technically, her risk of getting a gallstone is lower after she has it out, but still, you want her to have a healthier diet. So back to your question about the HIDA scan. So the HIDA scan pretty much is it's a nuclear test that shows if the gallbladder fills, and so you have this contrast type agent that will go throughout the biliary tree, and we try to see if it goes into the gallbladder, and if it doesn't go into the gallbladder, then we know that there's an obstruction there, and there's probably a stone. And so because we know that this patient has an inflamed gallbladder, we don't necessarily need to do the HIDA scan. We can just go straight to surgery. Yeah. All right. Does a gallstone form in the leftover duct? So we typically will take out the duct going from the gallbladder to the common bile duct. So there's really not a duct left over, but it can form in the common bile duct between the liver and as it drains down into the pancreas, through the pancreas into the duodenum. So it can form in there. All right, and then you would also give fluids. You can give Pedialyte, but that's basically oral electrolytes. But I would probably hold off on that until we get this all figured out. All right. So she was started on IV fluids. She was also given antibiotics. Surgery was consulted. She was taken to the OR. The gallbladder was removed, and she recovered well. Any questions about that case? So in the long term, would you have liver issues in the future from constant drainage? No. Usually you don't really have any issues after getting your gallbladder out. It does change the way you digest food. And so some people have like changes in like their bowel habits and all that, but it doesn't cause any like long-term significant damage to the system. Yeah, so since ultrasound is so cheap and non-invasive, is it bad to do it earlier in the diagnosis process? No, it's not. But you always, whenever you're doing a test, you always want to know why you're doing the test. And so if we get an ultrasound and it shows, something that we didn't expect, what are you supposed to do with that information if you're not expecting it? So, for instance, if a patient is having, if you think that a patient has, I don't know, like hepatitis or let's say actually if you think a patient has a kidney stone, let's go there, and you do an ultrasound and you see when you're scanning the area, you see that the patient also has a gallstone. Do you have to take out the gallbladder now and do that surgery just because they had a kidney stone? So you always have to balance it with what you think is most likely in the patient and what is going to be best for the patient. And so it is okay to do it earlier, but you have to just be careful that you're not going to be finding things that you need to intervene on, that you may not have had to intervene on, but now that you found it, now you have to do it. So it just saves patients like unnecessary procedures or surgeries and stuff like that. So yeah. Any other questions? Any questions about the format for the next few weeks? So next week we're gonna probably. So okay. So it's not going to be non-virtual. So what we're going to do is there's going to be one more case in this month. Or actually, there's going to be two more cases this month, and it's going to be in about 2 weeks or so. So next week on the 4th of July, it's not a mandatory meeting. So it's whoever wants to show up can, and we'll go through a case together. And it'll be a case that I've never seen before also. So we'll solve it all together. Sorry, I'm going to answer this really quick. If the patient was pregnant, does that procedure stay the same? Depends on how pregnant they are. They might need an open surgery versus the laparoscopic. So you'd want to check a pregnancy test. All right. So next week we're going to solve a case together, and I won't know the case, you won't know the case, and we'll work on it together. I will let you guys take the first stab at it. We'll talk about what I think, and then we'll see what the answer is as we go through. The week after that, we're gonna have a Q&A session. I'm gathering people that have experience in like the EMT world, that are MAs, the phlebotomists, whatever it is, like clinical experience, so that you guys who don't necessarily have that experience can ask them how they got that experience. Also, people that are in master's programs, like what their thoughts are about the master's programs, or also people that are in research, like how they went about getting research. And so we'll do a Q&A session so you can have a little bit of mentoring, have a little bit of advice through there. And then the last 2 weeks, in 3 weeks and 4 weeks, we're going to have 2 different cases, and they're going to be about abdominal pain. And so we'll go through it like we are doing these cases. The problem with those 2 weeks, though, is I am working on Sundays, so I will only have one day to do it. So what we're thinking of is having the first 4 groups go, and then so classes 1 through 4 will go one day, and 5 through 8 will join in on YouTube. So we'll have everybody kind of in one session, but we'll focus on 1 through 4 in this Google Meet platform. And then the following week, it'll be the reverse. So 5 through 8 will be here, and then everybody else will be on YouTube. So, and then from there, we'll probably we're thinking about maybe ending this cohort then, and then because of that, we can the program will end at the end of July. And because we didn't get through everything we wanted to, you're going to be able to join back in into the future sessions, and we'll figure out the logistics for that. Everybody who is using this for med school or other applications, you're still going to be able to do it. I'm still going to give you full credit for everything. It's just unforeseen circumstances with COVID, with how everything's going in my area, that I'm going to be working about 80 hours a week. I can't really give the time to do a really good job for this if we're doing it every week. And so I want to make sure that your education and what I'm teaching you is still good. So yeah. Will there still be live office hours? There will be. I will put together a time. We'll figure it out over the next few days, and this coming week I'll have a session for office hours. It'll probably be later in the day because I will be in the hospital. So hopefully we'll get off to the hospital around 5 o'clock one day. So we'll do it then. So just keep an eye out for that. Any questions? Any concerns? Anything you want to ask me before I move on to the next class? Okay. So if there's no other questions, I'll let you guys go, and we can talk about. If you guys have more questions, you just let me know. Just message me or send me an email, and we can go over a COVID case. I think one of the last weeks we had a COVID case, so but we can go over another one too. So that might be a good thing to do. All right, guys, take care. I'm gonna go on to the next class. Message me if you have any other questions.